A very good morning to everyone, and at the outset, I would like to thank MycoAsia for giving me this opportunity to make this presentation. And greetings from AIMS Bhubaneswar, Advanced Molecular and Diagnostic Center for Fungi. So, because this presentation involves audience who are not from medical background, I would want to put a disclaimer here that this contains many disturbing images and it is not for the faint-hearted. I would also want to declare that I have no financial disclosure, and the use of any company's product is for portrayal purposes and doesn't mean that I endorse these products. So the ultimate aim of medicine is to prevent disability and death. So mycology or medical mycology is a branch of medicine which also aims to prevent disease and death. So a journey of 1,000 miles begins with a single step. So similarly, the journey of medical mycology begins with identification of the fungi. So why identification is so important, and this we'll be discussing by taking examples. So the first example that I wish to give you is ringworm, which is a very common disease. And here you can see on the left hand side a photograph of a person with ringworm. Now, ringworm like lesions can be caused by psoriasis, by atopic dermatitis, lupus erythematosus, and seborrheic dermatitis. The other name for atopic dermatitis is eczema, and the other name for seborrheic dermatitis is dandruff. So, 20 to 25% of the world's population is known to have dermatophyte infection, although it's mainly considered to be a nuisance. Studies have found that it still has a significant impact on the quality of the life of the person who's suffering from him. And studies have found that when ringworm infection is chronic or when it involves more than one side, the people are anxious and they are depressed. So the other important or common problem that is very frequently seen in clinical mycology practice is fungal keratitis. Now fungal keratitis is the infection or involvement of the cornea, that is the transparent layer of the eye. And fungal keratitis, the picture that the patient presents can also be similar to bacterial keratitis and other microbial keratitis like viral keratitis or even keratitis caused due to pythium. Now, what's interesting is that it affects mainly agricultural workers, and if not treated, it causes blindness. And it is said that 95,000 to around 1,15,000 eyes are surgically removed globally each year because of fungal keratitis. And it is also estimated that 610,800 eyes will go blind globally each year due to fungal keratitis. So this means that this infection is really these infections are really troublesome. So moving on to the next problem that we frequently face in clinical mycology is the problem of invasive candida, and the most common ones that we find is candidemia. Now, candidemia is the presence of candida in blood, and it mainly presents as sepsis, that is fever, and it can be mimicked by bacterial infections. Now, we know that it mainly affects people who are already sick from other medical conditions, and it is mainly suspected when the fever doesn't subside even with antibacterials. It has a crude mortality of 81%, a very high crude mortality, and I would like to impress upon you that India has one of the highest rates of candida bloodstream infection in the world, with around 1,88,035 cases estimated every year. So going on to the less frequent problems, but like mucormycosis. Now mucormycosis, the clinical picture, that is the way the patient presents to the doctor, can be mimicked by orbital cellulitis caused by bacteria, It can be mimicked by cancer, it can be mimicked by vascular malformation or malformation of arteries, and it can be due to problem endocrine or thyroid disorders. So it mainly affects immunocompromised patients like those whose diabetes is uncontrolled, those who have blood cancers, etc. Now the problem of mucormycosis is that it can result in evisceration of the eye, wherein the eye, if the mucormycosis is involving the area covering your eye, the eye has to be removed, resulting in loss of vision, and the surgery is usually radical and extremely disfiguring. For example, here we have a patient who has mucormycosis on the left hand side, and this is how he looks after the surgery. Moreover, it is also associated with high fatality rate or high mortality, and around 54% of people who have mucormycosis die either due to it or due to contribution of other factors. And in some patients, the depending on the site of the infection, the mortality ranges from 46% to almost near 100% when more than one site is involved, one site of the body is involved by mucormycosis. The next picture is that of a case of Aspergillus brain abscess. Aspergillosis again is relatively rare compared to the other ones that I discussed initially. Now, Aspergillosis brain abscess can be mimicked by tuberculosis, bacterial brain abscesses, and cancers. Now, Aspergillosis or invasive aspergillosis mainly affects very sick people, those who are immunocompromised, secondary to transplant or secondary to cancer or its therapy, and even aspergillosis requires radical dissection or treatment sometimes. The most common organ that is involved is usually the lung, and many a times it requires removal of a part of the lung for its treatment in patients who can undergo that surgery. And as we can see, the case fatality rates range from somewhere between 40 to 90%. Moving on to some neglected tropical diseases, here I am showing you on the left hand side a photograph of a patient with mycetoma. Mycetoma occurs mainly in the tropical countries, and it is a neglected disease because nobody works on it, or there are not many people who work on it. There are not many therapeutic trials that are on it. So now mycetoma also can be mimicked by bacterial infection. Even osteomyelitis, that is infection of the bone, can present similarly, and some cancers also give a similar presentation. So this affects usually the poorest of the poor, and usually affects the people at the prime of the age where they are earning money for their families. So when this infection occurs and this infection is not treated, what happens is, during the later stage of the disease, the only treatment option that is left is amputation. And amputation itself, like this lady who has undergone a below knee amputation to treat her mycetoma, is definitely going to suffer economically and psychologically because of the infection. So till now, what I wanted to impress upon you is that fungal infections can range from being a nuisance to being extremely deadly, and that other infections can mimic fungal infections, and that they cause huge disability and death. Some affect very sick people and some of them affect very poor people, and it is estimated that 300 million people afflicted with serious fungal infections annually, and of these 25 million are at risk for dying or blindness. So the take home point here is that these fungal infections can be mimicked by other conditions, and that they can cause severe morbidity and mortality. And is there any treatment for them? Okay, yes, there is treatment for them, and it has been found that if the treatment is delayed, for example, in cases of Candidemia, there is a 20% increase in mortality. and the mortality is 90% compared to 41% for patients with Aspergillus pneumonia who have been started the antifungals or treatment later compared to the ones who were started early during the time of suspicion. Similarly, in cases of sinopulmonary mucormycosis, early treatment with the antifungal drug amphotericin B has been known to be having better outcome. So it's like the Indian adage that if you wish to kill the tree, you have to pinch the sapling when it's small, and when you take care of it, then it doesn't become a big problem and lead to death. Similarly, it has been found that 75% of not severely affected corneas and 60% of severely affected corneas can be salvaged if the antifungals are started in time, and then the visual outcome is also good in such patients. So what are the drugs that we use for treating patients with fungal infections? I have listed the four major classes that are used for treatment of invasive fungal infections. They are polyenes, that is amphotericin B, azoles, which have a group of agents like fluconazole, variconazole, posaconazole, isavuconazole. And then we have echinocandins like caspofungin, micafungin, anidulafungin, and finally we have nucleoside analogs like flucytosins. These are the most common ones that we use mainly in treating invasive fungal infection. Now proceeding further, I am showing you a table which shows the spectrum of activity of different antifungals. Amphotericin B is abbreviated here as AMB, fluconazole is abbreviated as Fluco, Variconazole as Vari, and so on. Now if you look at this table, I have shaded it green, yellow and red. Green means you can use this drug for treating the corresponding fungal infection. Yellow means that it has some activity and in some places it has fungistatic activity, while red means that this drug has no activity against the said fungus. So looking at this table, it is quite apparent that different antifungal drugs have different spectrum of activity, and there is no one cure for all except for amphotericin B, which is a broad spectrum antifungal, and we shall be discussing something about it in the coming slide. So going on to amphotericin B, as I already indicated, it's a broad spectrum antifungal, but you cannot say that I am going to use it in every patient of suspected fungal infection. And why do I say that is because the drug is very toxic, and if used indiscriminately, it can result in kidney damage that might range from mild to severe, resulting in renal failure and subsequent death. So, and it is also extremely expensive. In Indian rupees, the cost of amphotericin B for treatment of a case of mucormycosis is rupees 35,000 per day, or around $425 per day. And if you then go on and calculate the amount that is needed for administering amphotericin B alone in a case of mucormycosis, that is roughly around 6 weeks, it costs somewhere around 7.5 lakh to 15 lakh, or 9,000, roughly around 9,100 US dollars and 18,200 US dollars for treatment of with amphotericin B alone. So the point is amphotericin B is extremely toxic and is expensive. So is there any other drug that can be used for treating, a less toxic drug that can be used for treating fungal infection? So the one that we have is Variconazole. It is active against many fungus, but it is mainly used in treatment of Aspergillosis. Now even this drug, though less toxic than amphotericin B, has side effects like it can cause liver damage, and again the liver damage might range from mild elevation to liver failure if not used rationally, or if the dosing is not proper. And then another major problem of Variconazole is that Variconazole has many drug interactions, and as I told, Aspergillosis usually affects those people who are very sick. So and they have either blood cancers or they have undergone a hematopoietic stem cell transplant. In such group of patients, it is used as a prophylactic measure. So in such group of patients, the patient is not only receiving the antifungal Variconazole to prevent fungal infection, he is also receiving immunosuppressants, and there can be interactions which can further increase its toxicity. Looking at its cost, the cost of Variconazole per day is 14,000 rupees in Indian currency, and in a study it was found that the cost of treatment is around 37,000 US dollars to 60,000 US dollars, higher than those patients without invasive aspergillosis. So moving on to the next drug that is less toxic, that is echinocandins. Now echinocandins have a relatively narrow spectrum. They are used to treat a common invasive fungal infection like invasive Candida infections, and let us look at it. As I said, this is less toxic compared to Amphotericin B and Variconazole. But it is associated with infusion reactions, that is, patients who are given this drug may develop chills, fever and thrombophlebitis, and it has to be managed symptomatically. And looking at the cost again, the cost is around 13,510 rupees for one dose of a popular drug that is used for treatment and belongs to this class of antifungals. And the mean total cost per patient for treatment of Candidemia has been estimated to be around roughly 50,000 US dollars to 150,000 US dollars. So treating fungal infections is by this time it is pretty clear that antifungals, although they are available and if they are started in time, they can save life, they can save limb, but they have toxicity and they are very expensive. So as I said again, summarizing my previous slides, I said that fungal infections, they are mimicked by other infections and cancer, and they have a ability to cause disability and death, and that the treatment can prevent disability and death, but the treatment that is used, the drugs that are used are highly toxic and they are very expensive. So what you need to do is you have to be extremely cautious. You have to be sure that the patient has fungal infection before starting him on antifungal medications. And because they are very expensive, you don't, and very toxic, you don't want your patient to die because of toxicity, and you also don't want him to land up with a begging bowl. So you have to be extremely cautious, extremely sure of the patient having the fungal infection before starting the antifungals. So another reason why identification of fungi is very important is because some fungi have outbreak potential. So the one that is in everyone's memory recently is definitely the outbreak or epidemic of Mucer Mycosis. Now the first news reports that came were in December 2020, wherein there was a news that the black fungus, which is a misnomer for Mucer Mycosis, is spreading in India. And then there were reports that there were wards that were opened for treating only patients with Mucer Mycosis, and several hospitals were shut down and opened only to cater patients with Mucer Mycosis. Subsequently, people jumped into the publication business, and then each week we had a black fungus, we had a white fungus, we had a yellow fungus. So, there were memes on the internet, and one meme said fungus after every week. Abhi humko color change chahiye. And the medical mycologists who were looking at this news of black fungus, white fungus, yellow fungus didn't want to stay on the face of this earth, because these were all misnomers and all the things trying to grab attention and not very scientific when it came to naming these diseases or naming these fungi. So what was this outbreak about? This outbreak was about COVID associated Mucer Mycosis, and by around 30 June 2021, India described around 41,000 cases of Mucer Mycosis with around 3,230 deaths, which was huge in number. And then studies, of which one study of which even I am a part of, a multi-centric study, we did a case control survey, and we found that indiscriminate steroid use, zinc supplementation and uncontrolled diabetes were the major risk factors for this outbreak. And suddenly we don't have, the cases of Mucer Mycosis have come down suddenly. And why this has happened is we are not sure, and this could mainly be because the physicians, the patients, everyone become aware that this fungal infection can happen if their blood sugars are not controlled, if they are indiscriminately taking steroids, and possibly this was the reason why the outbreak of Mucer Mycosis in India came to a halt. So proceeding on to the next one, that is affecting India. Now India is experiencing a hyperendemic outbreak of chronic and recurrent or relapsing dermatophytosis. The ringworm, the very first slide that I showed you people, was an uncomplicated ringworm. But in India, patients are developing ringworm infections which just don't go away, or which come back and which involve huge body surface areas. I shall be showing you the pictures in the next slide. So one study that was done at a tertiary care center in Chandigarh found that 10% of their patients had recurrence, while another done in the northeastern part of the country, that is Sikkim, found that around 61% of their patients had recurrence. So a multi-centric study was done from having 13 centers across India, and this study found that 27% of all the cases who come with complaint of ringworm infection to the dermatology clinic, they have chronic and recurrent dermatophytosis, and surprisingly around 78% of them had chronic, that is lasting for more than 4 to 6 weeks, and 22% of them had recurrent dermatophytosis. So this ringworm infection has, this outbreak or this ringworm has emerged as a major problem in India, and has become a nightmare for practicing dermatologists who seem to be not able to treat this ringworm infection, and the people who are affected by it are having anxiety and depression, as I told in my previous slide. So this is how the patients of chronic and recurrent dermatophytosis in India are presenting. Look at the amount of the body surface area that is involved. In these two cases, almost a large amount of the body surface area of the patients is involved, while in these cases at the bottom you can see that there are ring-like lesions, big ring-like lesions, and involvement of again large body surface area. So this outbreak or this emergence has been thought to be because of steroid and antifungal fixed drug combination. So you just have to go to any pharmacy across India, and because these are over the counter, and you just speak to the pharmacist, the pharmacist will always hand you over a fixed combination of steroid and antifungal drug, that is something like clotrimazole and beclomethasone, and surprisingly these drug combinations, fixed drug combinations, are much cheaper compared to the ones that contain only the antifungals. So this is one reason that is attributed to the current hyper epidemic of chronic recurrent dermatophytosis. The other one is a lifestyle change. a lot of youngsters, a lot of people these days are wearing tight garments made up of synthetic clothes like jeggings and jeans, which are not breathable, and because they are not breathable, there is some amount of sweat, and that sweat helps this fungus to persist on the skin. While the mycological explanation or the mycological hypothesis was that this was due to a new drug resistant bug or new drug resistant fungal species. And a study was done, and it was found that this species, this epidemic or this outbreak was due to a terbinafine resistant fungus called as, which was named as Trichophyton indotini. So Trichophyton indotini was the reason for the outbreak or hyperepidemic of the dermatophyte, chronic and recurrent dermatophytosis in India. Now moving on to, so we looked at two fungal infections that caused outbreaks, countrywide outbreaks. Now let us move to infections that have ability to cause continental outbreaks. So the one that I'm going to discuss here is sporotrichosis. Now sporotrichosis is a question for people, for MBBS students when they are writing their MD entrance examination, and sporotrichosis of humans usually presents like this. They present as lesions along the lymphatics. There are multiple ulcerations. There are multiple ulcerations or wounds around the lymphatics. Now this sporotrichosis is mainly caused by Sporotrix sensu stricto, and previously it was known to cause outbreaks. Now the amazing or the interesting thing is the discovery of animals in the continent of South America, across Brazil, across neighboring countries. They are developing these lesions, and when they investigated these lesions, they found that these lesions were due to Sporotrix brasiliensis, and this has crossed borders and is almost occurring across a lot of countries in South America. Right. So here we have a fungus that has ability to disseminate far, and these infections are mainly occurring in cats, and they have the ability to be transmitted to their human handlers. So this is the kind of outbreaks or kind of fungi we are currently dealing with. So now no discussion these days is complete without discussion of a fungus that is silently sweeping the globe, and this fungus is multi-drug resistant, and everybody would have heard about it. So the fungus that I am talking about is Candida auris. Now Candida auris was discovered in 2009 by Sato and colleagues in Japan, and they found it in the ear discharge of a female patient. And after 2009, this is the map of the world, and the areas that have been shaded red are the places from where Candida auris has been reported. So imagine a fungus that has within almost a decade spread globally. But is it the spread that is worrying? No, it is not the spread. What is important is that this bug is highly drug resistant, and by highly drug resistant we mean that currently around 4% of these isolates, some of these bugs, are resistant to all antifungals. They are resistant to all known antifungals, right? So other point is that patients can get colonized, that is, this bug can live on their skin, on their body surface, and then subsequently when the immunity goes down or when there are additional risk factors, the patient can develop invasive Candida infection. And because it is highly drug resistant and because it can cause long-term colonization in patient, and it also has the ability to persist in the hospital environment because other than being drug resistant, this is also resistant to the disinfectants that are used in the hospital. So it can spread in healthcare settings. So much so that this has resulted in a paradigm shift. That is, this is the first time a fungus or a yeast is acting like a bacteria, and in several countries the intensive care units had to be shut down to contain the outbreaks of Candida auris, and all healthcare providers who work in intensive care are currently worried about this fungus. So another important part about identification is that it tells us about the prevalence and distribution of fungal disease. So this is a picture that I have taken from Global Action Fund for Fungal Infection website, that is GAFI website, and it tells us about the estimate or burden of fungal infections globally. And they have estimated that around 300 million people are afflicted with serious fungal infections, and 25 million of them are at either risk of dying or losing their sight secondary to fungal infections. Now, why this is important, why this could be done was because fungal infections were identified at the first place. So this data is important to convince policymakers and companies to invest in mycology so that we have more research for identification of risk factors, for identification of the epidemiology of the disease, so as to develop preventive and control strategy to prevent the spread of this infection, as well as develop antifungals for bugs like Candida auris, which seem to be currently developing pan-drug resistance. Right. So how are fungal infections identified? So whenever a patient with suspicion of fungal infection comes to the hospital, the doctor sends the sample to the mycology lab. The sample either gets many of these samples, like the biopsies, which are considered as gold standards for diagnosis of invasive fungal infections, and exudates or pus or sputum or any other samples. Such samples are subjected first to microscopy, and if there are fungal elements like yeast or hyphae, they are reported to the doctor, and the clinical mycologist and the doctor sit and discuss whether this patient is a candidate for invasive fungal infection and take a decision on treating him appropriately. Some part of this sample is also cultivated on appropriate media, and now in the few months we have PCR based tests for diagnosis of fungal infection also available. So after cultivation, if there is a growth of yeast, it is usually subjected to biochemical reactions for its identification, while if there is a growth of a mold, it is identified by morphology. Right. So all the samples except blood are subjected to this pathway, while from blood usually the blood is subjected to blood culture, and again following the growth of the fungus, whether if it's yeast, it is identified by biochemicals. If it is mold, it is identified using morphology. Blood is also used to put up certain serological tests like serum galactomannan and serum beta-D-glucan, which are fungal antigens which are present in the blood of patients with invasive fungal infections. Now they are also tricky tests to interpret, and usually the physician, the treating doctor and the clinical mycologist sit together, discuss these tests before diagnosing the patient with invasive fungal infection. Having said that, these tests have actually helped in rapid diagnosis and management of fungal infections. And recently there are certain PCRs like PCR for Mucer Mycosis, PCR for Aspergillosis, that are available for diagnosis of invasive fungal infection. And recently there MALDI-TOF is a technology that is revolutionizing clinical microbiology, and it can also be used for identification of fungi, both yeast and mold. So all cultured fungi can be identified by sequencing of the barcoding region, which is gold standard. But this facility is not available in all laboratories, and if and when this facility is used, we can identify cryptic species. Now cryptic species are hidden species. Certain fungi like the Aspergillus fumigatus is not composed of only one organism. It is actually composed of several subspecies, and these subspecies are called as cryptic species because they cannot be identified by the routine methods, and they need to be identified by subjecting them to PCR and sequencing of the barcoding region. So why is it important these days is because some of these cryptic species are known to be drug resistant, and if the antifungal susceptibility, which is not said to be mandatory for molds, is not done prior to administering the drug, it might result in the patient not responding to the drug and succumbing to the illness. And this concept of cryptic species is also applied to yeast and yeasts as well. So looking at so summarizing, identification is important because identification of fungi or fungal infection is important because it helps in diagnosis, it helps in treatment, it helps in identifying epidemics or outbreaks, and identification of emerging and re-emerging infection, and the identification of prevalence and fungal disease distribution helps in influencing the health policy and helps in getting funding for research. So looking at all these factors, the Indian Council of Medical Research has established a network of diagnostic and research centers across India with PGIMER Chandigarh as the mentor institute. So we are a part of it, and we are currently helping people across India in identifying fungi and performing their susceptibility. We also accept medical fungi for their deposit, and we make them available in future for anyone who wishes to do research on them. And we also conduct workshops in medical mycology. In fact, a workshop is scheduled to be held on between April 21st to 23rd of 2023, wherein 30 to 35 people from across India and possibly a couple of them from abroad will be trained in the diagnosis and diagnosis part of the medical fungi. And we also offer hands-on observership for people who wish to come over to Bhubaneswar at a laboratory and learn about how the samples are processed for diagnosis of fungal infection, and how the different PCRs are applied for diagnosis of invasive fungal infection. So that is about our center, and if ever you need help for identifying any medical fungi or educational material for medical mycology, feel free to contact us. This is our email address. We are available on the Twitter also, as well as we have our own website. Right. So thank you a lot for your patience. Good day. And I take this opportunity to thank MycoAsia for giving me this opportunity and platform to make this presentation. Thank you, Dr. Shruti Vasant, for inviting me to this talk, and thanks a lot to Dr. Shinai for having arranged this talk.